Hello, this is Mary Grady, and I am here to give you kind of a little bit of a show here and talk about asthma. I wanted this to be like a short little supplemental lecture that could help you, like an overview of things. But I also want to recommend you reading the material in the class reading list as well, because that's like very helpful as well. Well, what is asthma? Well, asthma is a chronic inflammatory disease of the lungs. It's when the airways are in a persistent state of inflammation. It's characterized by recurrent episodes of wheezing, being breathless, chest is tight, you're coughing. These episodes of asthma or these asthma attacks can be short, long, and they can be chronic. You can have a chronic condition with asthma where they keep occurring. Even when no attack is occurring, people that have asthma and their asthma is not treated, they have inflammatory cells. Like if you were to draw their white blood cells with a diff, their eosinophils, their neutrophils, and their lymphocytes might be elevated. Also, the inflammatory cells can be found, these eosinophils, neutrophils, and all these things that come to the site when something is inflamed can be found in airway tissue. Asthma in early life, when it's not treated properly, can lead to irreversible decline of pulmonary functioning in adulthood. So there is a need to care, there is a need to control, because if something is not controlled, it can lead to permanent structural changes, and the airway can start to remodel itself, and it can start to change. If you look down here, it says right here, common condition for children under 10 years, and accounts for 50% of the cases. So what I just said about asthma remodeling airways makes it very, very important for us to do good patient teaching, good patient education, so that parents at home can monitor their child's condition and can keep them out of the hospital. So what are some things that are going to trigger this, okay? We saw back on the other things, some of the causes could be genetics that's causing this. But also a big thing with asthma is allergies. You're sensitive to something. If you look there, the pollen, animal dander, house dust, mold, pillows, feathers. And when someone is diagnosed with asthma, one of the first things you do is you talk to people about, educate them on how to change their environment. I've seen a lot of parents that are smokers, their children have asthma, and that just makes things worse. So working with the parents to get a patch or ways that they can monitor their smoking. Sometimes it means taking the stuffed animals out of the house. Maybe sometimes it means getting rid of the family dog. Just so you know, other things contribute to it besides allergens. Temperature changes, humidity changes. In the fall and the spring, you see a lot of cases happening. Endocrine changes. A lot of times when people are going through puberty or there's hormonal changes, that can trigger an attack in people that are prone to this condition. And emotional stress. Stress in general. We can't rule out stress. It affects every single thing that we have going on. They also have found that some people, maybe it's a drug that you're on that's triggered asthma, this problem, or exposure to something in your workplace. And you will see some people that have asthma conditions only when they exercise. It's exercise induced. And then those are the folks they give an inhaler to, teach them how to use this bronchodilator, because we don't want to say, no, you don't ever have to exercise, because exercise is pretty important. So what's the pathophys? I've kind of listed it here on the PowerPoint, and I'm not going to read you word for word on the PowerPoint, but I am going to give you a little bit more information. You have this PowerPoint. You can go back and read the slides at any time. I'm just kind of pointing out some of the big things I would like for you to note. The big thing here is airways severely narrow. They narrow, they spasm, they constrict, and they get blocked with mucus. I want you to note that the mast cells and the bronchial mucosa release inflammatory mediators such as histamine, prostaglandins, and all of these good things. And these substances stimulate your parasympathetic nervous system to cause those bronchial smooth muscles to constrict. And when they constrict, it also increases the capillary permeability and allows plasma to escape and lead to mucosal edema, which causes all of those things you're seeing there, like the airway spasming and narrowing and getting blocked with mucus. This is very important. Airflow decreases. Gas gets trapped, the alveoli hyperinflate. Air can't get out the way it needs to. Atelectasis starts to occur in regions of the lungs where the little alveoli just start to collapse. And you have that labored breathing. I look here, I just realized I have a typo there. Note that when an attack is prolonged, with all these things happening over 4 hours, the basophils and the eosinophils, those things we talked about before, get activated, and they start to cause damage to the airway epithelium. More mucus and narrowing of the airways happen. That's your body's way of sending things there to try to help you, but in this case it's hurting you. So you have to stop the attack early on and prevent it from going on so that damage does not occur to the lungs. The signs and the symptoms we have here, I've already talked about some of them, like with the wheezing, the tightness of the chest and the coughing, tachypnea, using accessory muscles, tripoding. You start to see tripoding posturing. Also note signs of hypoxia, such as increased restlessness and irritability, unexplained confusion because air can't get to the brain real well. Respiratory rate goes up, heart rate goes up, and you start to see this fast breathing. Also, just know that asthma that is not controlled, you might have people that have nocturnal awakenings where they're coughing at night. Also on this list, prolonged expiration of your breathing, your breath sounds start to sound diminished maybe, more retractions. I want to note that with pediatric patients, their airways are much more narrower than an adult, and this causes a greater increase in airway resistance. More effort is needed to force air through the trachea to the lungs. Narrow airways, like small anyway, they're going to clog easily. Children, and also remember that children under 6 use their diaphragm to breathe because intercostal muscles are not mature. So that's why you see this being more respiratory distress condition in children. In respiratory distress, the negative pressure caused by movement of the diaphragm draws the chest wall inward, and this produces those retractions that you see, this negative pressure that the child is having. Retractions are just nothing more than sunken areas caused by those negative pressure, where you see the ribs or you see the sternum or a tracheal tug. I also want to point out when talking about children have a higher metabolic rate and thus have greater oxygen consumption needs, and this increases even more with distress. I also want to point out children also have less muscle glycogen reserves, so rapid muscle fatigue happens when they have to use those accessory muscles for breathing. Children also have unique risk factors for asthma. You have children that are premature at birth, and this increases their risk for asthma. Maternal smoking before they're even born or early in life increases their risk. Or an infection early in life like RSV or parainfluenza or adenovirus, those things make it make that child more prone to have asthma later on. So this is something that I wanted to point out. The testing here, before I go into testing, I just want to mention that the asthma with someone that's pregnant is very common because that's called stress on the body. And that it's pretty common. 8 to 10% of women actually will have asthma attacks or have a problem if they're asthmatic during their pregnancy. They've noticed that a lot of these exacerbations occur between 24 to 36 weeks gestation of the baby. If an asthma attack continues, just keep remembering oxygen's going to the baby too. You could have premature births for moms that are asthmatic. That's very common. And it increases a lot more complications. So keep that in mind with our pregnant patients. Testing, what are we going to do here to look at everything? X-rays, ABGs, pulmonary function test. All of these are very, very important. Even an allergy test to see if you are allergic to something that could be something that you could look at. So that's very important. This ABGs here, I would go back and I would look at the ABGs that you had in your last class so that you just kind of remember what that means for respiratory distress. If you look here, the treatment plan, the key word on this page is tailored to each patient. It depends on what is happening to that patient. For example, some people may need humidified oxygen, some may not. I would put everyone in a semi-Fowler's. Laying flat on your back is never good for breathing. Also, just to kind of note with oxygen, with most adults you can use a nasal cannula, but with children you might see different things used. You might see like an oxygen tent, oxygen hood, oxygen mask, but the important thing is for all ages is humidified oxygen helps to loosen the secretions. So you just kind of pick they have those little sailing things, bottles that attach to the oxygen on the wall so that it will humidify it. Also, another thing that I would really look at here is look at the drugs, but pay very close attention to bronchodilators for the test. Also note that in giving these medications, aero chambers are usually always used in children, and they're starting to become more used with adults for inhalers, because there's no way you're going to get a child to breathe in and to take an inhaler the way it's supposed to. So that's a very important thing to keep in mind. As far as the drugs go, I want you to know when you look at a lot of these drugs, a lot of them are things that cause fight or flight response. Just remember, bronchodilators act on the sympathetic nervous system, not the parasympathetic. Bronchodilators do not decrease the production of mucus or the production of histamine. The bronchodilator smooths muscles, relaxes, and bronchodilation occurs. They act on the sympathetic nervous systems and do not decrease the mucus. So to get rid of mucus, if that's a big problem, you may need other treatment plans. Did I just have 2 of those? Maybe I did. Okay, so patient teaching tips. What are we going to teach our patients? Think about all the things they need to use at home. Do they need to use a peak flow meter, which is a device, if you look in your book, it shows you that you can measure the pressure of how hard it is for you to breathe out every day, and we give our patients a plan, like I may have mentioned in class, where the plan shows you your green zone, your yellow zone, and your red zone. When you're in your green zone, everything you're doing is good. Keep doing it. When you're in your yellow zone, there's a plan. Maybe it's to take extra aerosols, extra inhalers. Maybe it's to get on prednisone. But it's something that says, okay, something's happening, causing me to not breathe as effectively as I normally do. Now, everybody's respiratory levels are different based on the size of the person and the person's lungs. Then in your red zone, that usually tells people get to the hospital. Since we've started teaching people how to use a peak flow meter, especially with children, which remember is 50% of our cases, we've had less people coming into the hospital and better control at home, which is going to be better outcomes for those children as adults. Because remodeling of my airways when I'm a child is going to affect my breathing when I'm an adult. Teaching people like when to go to the hospital, when to call the doctor, those are very important things. Some things that are nice to know, I've kind of wrote here. I just wanted to point out here that sometimes if you get a respiratory infection, it may trigger an attack. So that's something to know about or to think about. Also, another thing I would like to point out is some people think that asthma is an autoimmune disease. Not only does it run in families, but they think it's autoimmune. So that's something to think about. My show is over, but before I end it, I just want to talk about one more thing. I would go back and I would look and think to myself, what are things that tell me someone's asthma is getting worse? Maybe it's the color change of the skin. Maybe it's the level of consciousness changes. Cyanosis around the lips, the capillary refill on your nail beds, cool clammy skin. Agitation, lethargic, increased confusion, and worsening hypoxia are all things to think about, because maybe if the asthma attack goes into something called status, where it's not stopping and it's prolonged, then that's going to become a medical emergency that's going to have to be dealt with, because someone is going to get very, very tired, and the air is not going to be coming out, and they're going to get that muscle fatigue, and that's dangerous. Sometimes in those cases, you'll even see them use epinephrine in an aerosol format or an epinephrine sub-Q injection to try to open up those airways so that you don't get to such a serious point there. So this was like a little mini version of asthma. I hope you have found it helpful. And I will kind of end this now. And I think that's about it. Take care. Bye.